Now we come to the fourth session, the Dr. Gentili's Memorial Symposium. I am currently in Manchester. The Manchester Department of Neurosurgery and Clinical Neurosciences is one of the oldest in the country and certainly largest in the country. Sir Jeffrey Jefferson, as all neurosurgeons will know, of neurosurgery, an important historical figure. Again, as with Dr. Gentili, set not only Manchester neurosurgery, plus British neurosurgery and world neurosurgery. In fact, Sir Jeffrey Jefferson was the co-founder of the Society of British Neurosurgery, as well as the leading light in founding the WFNS. And so this session, the fourth session, we have got Dr. Spetzler and giving the talk, and it will be chaired by Mr. Daniel Holsgrove. He's the vice chair of the Manchester Center for Clinical Neurosciences and main lead for neurosurgery. And it's a real pleasure and privilege to invite him to chair this session. Thanks.
Thanks, Naren, and thanks for organising this Memorial Symposium. It's very moving to hear the way Dr. Gentili has touched and had such an impression on so many neurosurgeons from around the world. So thank you. So to start this session, it's my pleasure to introduce our next speaker, Dr. Robert Spetzler. Somewhat of an impossible task to summarise his career into a few sentences, and I'm resultantly understating it in doing so, so apologies for that. But he's best known for his leadership as Chair, CEO and President of the Barrow Neurological Institute from 1984 to 2017. And during that time had a huge role in education and training for both residents and also a huge number of visiting fellows. He's published extensively, received multiple awards and accolades, but relevant today, specialising in skull-base and cerebrovascular surgery, he's built up vast clinical and operative experience in these areas, including more than 6,000 aneurysm surgery cases. And he's therefore exceptionally well placed to present to us what the future does or doesn't hold for aneurysm surgery. So over to you, Dr. Spetzler, please.
Can you see my screen?
Yes, we can, yeah.
Yeah. Well, first of all, my apologies. I was diagnosed with COVID just 2 days ago. And trying my best. If I'm a little, please forgive me. Naren, thank you for organizing this. It is an absolute privilege to be presenting at a symposium designed to honor Fred, and really Fred and Gina. I will miss Fred's smiling face, which I saw around the world, and particularly pleasant when it was accompanied by his beautiful Gina. And I couldn't find a statement that more encapsulates as Fred than the one Gina gave earlier this year, which is Fred lived and breathed neurosurgery. It was his life, his passion, his fire. So yes, we will miss him, and the beautiful accolades that my colleagues have given in the previous sessions will be remembered by all. When we talk about the history or treatment of aneurysm, it goes all the way back to 1855 when Horsley performed carotid ligation. 1933, Norman Dodd wrapped an aneurysm. 1938, the modern treatment began with Walter Dandy clipping an aneurysm. And carotid ligation remained very popular in the 50s to 70s until the introduction of the GDC. When I arrived at Case Western Reserve after finishing my residency, carotid ligation was still the treatment for all anterior circulation aneurysms. And despite the high published stroke rates and recurrent hemorrhages, this treatment remained popular, surely because it was so simple. So my chief resident, Richard Roski, and I reviewed all the cases that were treated with the Silverstone clamp, including the carotid artery. And the immediate results were so bad we couldn't publish them. But the long-term results, surprisingly, were also very sobering. With almost an 8.5-year follow-up, there was more than a 16% stroke rate on the side of the carotid ligation and an almost 10% subarachnoid hemorrhage rate, which is very close to the normal history. Let's review, the randomized studies, durability of the constrand, and the risk of rebleeding. There are basically 4 prospective randomized trials, all of which ISAT at 1 year follow-up showed a superiority for coiling, but not at 5 and 10 years. BRAD, there was no difference at any time point. FINISH, there was no difference. Lee study, there was no difference. So what were the concerns? It was patient selection, durability, rebleeding, coil migration, and treatment. ISAT, if you looked at the 1-year follow-up where there was a significance, there's no doubt that with clipping, there was a higher perioperative morbidity and mortality rate than with coiling over that first year. At 5 years, there was no significance between the 2 randomized arms. And at 10 years, they gave a follow-up only of the English cohort. And they used as an endpoint, instead of modified Rankin score, they used 10. They used death, and there was a difference that was 17% for the coil and 21% for the clip, which was significant. What was unique in ISAT is that ECMO required. So that means basically that the endovascular surgeon and the microsurgeon both had to agree that this is an aneurysm that could be appropriately treated by either technique. Only about 1/5 of the potential candidates were enrolled, and the vast majority were in grade 1 and 2, much better than, for example, in BRAD. And there was a 15-hour delay for those that were clipped as opposed to coiled. But because they were already randomized naturally, these 11 subarachnoid hemorrhages and 12 deaths belonged into that cohort. Unique is also that there was no post-op documentation required for the clipped cohort. There was a higher rebleed rate for coiled aneurysm, 16% versus 12%. And despite the equipoise requirement, 30 patients were not clipped at random craniotomy, 26 of which were then coiled. Also, as is well known, is once they were coiled, almost 20% required retreatment. And this led to the BRAD study. And this randomized intent to treat analysis, single center study with follow-up up to 10 years. Last patient was entered in 2007. There were no anatomic inclusion or exclusion criteria. There were 4 neurosurgeons, 2 endovascular neurosurgeons, all with more experience than 50 independently treated aneurysms. And the goal was to treat within 24 hours. Crossovers were at the discretion of the attending physician. So if you thought that there was a better treatment for your patient that was right for you, you could decide whether to treat them or to cross them over. And primary outcome, modified Rankin score greater than 2 at 1, 3, 6, and 10 years. And then sentinel events, which were repeated subarachnoid hemorrhage, retreatment, or death. There were 362 assigned in the study. 356 were treated, 6 died prior to treatment, 3 in each group. Of the 178 patients assigned to coiling, 64 were crossed over to clipping by the endovascular surgeon. That's 36% of the aneurysms assigned to coiling that they felt were better treated with clipping. Of the 178 assigned to clipping, 1 was crossed over to coiling. So the total number of clipped aneurysms was 68%, and the total coiled was 32%. what were the reasons that patients were crossed over? Well, if you look, those with large hematomas, they had a very poor modified Rankin score, and all of these remained relatively poor. Only about a quarter of them had some improvement by the end of the study. But all of those naturally were crossed over to clipping, just to remind you that they will be, when we talk about direct treatment, part of that group. So what were the results? Well, if you look at the results, for all the patients, there was never any point at which there was a significance of one treatment over the other. In order to compare with ISAD, we looked at the anterior circulation aneurysms, of which we had 318. They had good anatomical parity as to their location. And if you looked at them, again, p-values were non-significant for all categories. When you look at the actual number, if anything, there's a trend to patients that were clipped doing better. More importantly is that when you look at death at 10 years and 10 years with carry forward, there was absolutely no difference as opposed to what we saw in ISAD. When you look at anterior circulation aneurysms now at the actual treatment, those that were coiled and those that were clipped, 99 ended up being coiled, 215 ended up being clipped. Of those that were coiled, 52% or 44%, if you include the carry forward, had a modified Rankin score of greater than 2. So despite the fact that those patients that were crossed over, which tended to be the ones with the hematoma, the ones with the very large aneurysms, the very small aneurysms, the clipped cohort actually did better, even though not statistically significant. And if you look at death, there was absolutely no benefit to coiling as suggested by the ISAD trial. In fact, the number of deaths were smaller in the clipped cohort than in the coiled cohort. What about retreatment, aneurysm obliteration, subarachnoid hemorrhage, and death? Well, if we look at the result of what the intent of treatment is for, it has only one: to prevent re-hemorrhage from an aneurysm. Well, retreatment after 10 years after discharge was almost 20% in the coiled, not any different than in the first year, I said. And in the clipped, there were only 2 retreatments out of 241, less than 1%. Obliteration. For the clipped cohort, it was 87% in the first year, 52% in the first year with coiling. And if you look at coiling, those numbers just continue to decrease, where with clipping, they stayed the same or improved. And finally, what is it really all about? We had 2 rebleeds, and they were all both in the coiled group. So that's 2 out of 83 treated with coiling that bled. Both of those ended up dying. That is significant to the P 0.039. Critical question is really treatment effectiveness. How protective is coiling? How durable is the endovascular construct? And the trouble is, naturally, we get good obliteration, and then with follow-up, it recurs, and it recurs, and it recurs. Subarachnoid hemorrhage, aneurysm growth is the key for increased risk of bleeding. And if you have 22% at 10 years that are not completely obliterated, then you have a problem for long-term. Aneurysms are a long-term problem. It's not they do well the first year or the second year. It's more when you're going down to the 8th, 9th, 10th year. Just like in the Helsinki trial, their subarachnoid hemorrhages occurred in year 8. Recurrence is a concern. Here's one coiled aneurysm gone with recurrence. And here you see the angiogram after the coiling. You see the coiling mass. And at surgery, you see the coils migrating out of the aneurysm. Your coils are migrating out of the aneurysm into the optic nerve 8 years after coiling, presenting with visual deficit. Here's a neuro-ophthalmologist at our shop, progressive third nerve deficit 3 years after stenting and coiling. And here you see the coils going into the third nerve. It's not just coils. Here's a young man that was treated eventually with 7 stents to try to limit it. He was referred to us after his continued visual loss. And here you see the aneurysm lighting up. And here you see the blood going through the stents into the aneurysm. Here in the short, it's just as you follow up with the angiogram, the first portion doesn't look so bad, then worse. Time of surgery, here are the stents. We ended up occluding the internal carotid artery, and I won't bore you with the detail of that. And here we see the post-op. It's no longer lighting up. There was no change in the exam. Here's the bypass coming in. But 3 months post-op, aneurysm basically gone with dramatic improvement in vision. From technique perspective, I think it's important. We published a big paper on retractorless surgery. And here's a complex aneurysm that was coiled and stented, and no retractor in place as we try to fix this aneurysm. Obviously, this is not fixable. So we did place a stent. We did place a retractor, but it was only to tampen out the temporal lobe. We did the bypass. And here's the bypass. 6 months later, you can see it filling the entire hemisphere. Aneurysm is no longer filling. Question of the hemorrhage, a little bit more than the subarachnoid hemorrhage we tend to see without a cause. And when we repeat the angiogram before discharge, we see a blister aneurysm at the top of the basilar artery. Well, that's really not an endovascular treatable aneurysm. Here we're going down to the aneurysm, opening the cistern. I like bipolaring the posterior communicating and cutting it so you don't have little clips in your way. And then you come down to the aneurysm. We're seeing the basilar artery, superior cerebellar, third nerve on that side, posterior cerebral on this side. And here you see the aneurysm sticking right up at the top. All the tension that we create is all toward the aneurysm, so we don't place any more stretch on the wall. And then with it exposed, I like reinforcing the neck with a little bit of cotton. And then with quite a bit of downward pressure on the basilar artery, clipping the aneurysm. And that was nicely disappeared. And just to emphasize that aneurysms, even when they're very large, and that they can be treated without a retractor. So here we're looking at the aneurysm, just slight retraction coming in from this side, because there was also an aneurysm on the middle cerebral artery that was small, but giving us room, even without rigid retractors. I call it dynamic retractors, where you're using the instrument to provide room. And with the beauty of ICG, we can be certain that the vessels at the base are still patent, because the biggest risk here is really occluding the anterior cerebral artery down below. And here you can see the post-op result. The problem with recurrence here, and there are no PCOM. So our plan is for basilar artery occlusion, which is basically flow diversion. And I just wanted to point out that this is not something new, that this was first published in 1960s by Lester Mound and Tavares. And here, I always, when I see those basilar artery aneurysms, I could not clip the neck of the aneurysm. So now we're below the superior cerebellar arteries, where there are no perforators. And we already know that he has good PCOMs. So here we go. Here we see the post-op, and then we see the follow-up, nice occlusion. What do you do when this is 3 times the patient was coiled, and our plan was to do the same thing because there were no post-op communicators. except to add on a bypass to create an artificial one. We're going down to the basilar artery. We're separating out the SCA's third nerve. And now I'm placing a perforated a clip over the aneurysm, P, posterior cerebral, superior cerebellar artery. And the posterior cerebral artery is inside the opening in the clip. And to make a long story short, we were able to clip it completely so that it would look like this afterwards. So even though you thought we're going to have to do a bypass, inspecting beforehand, what do you do with an enlarging? I'm sitting here, really not a good option endovascularly, small vessels so far out. So we used the lateral supracerebellar infratentorial approach. And here you see him going down to the ambient cistern, the extra scarring, and I'm sure that was related to its relationship to the tentorium, opening the tentorium, no retractor in place, despite the fact that this patient is not in the sitting position, shrinking back the edges of the tentorium, and then seeing the aneurysm, which is sitting right here. Relatively easy to get proximal control, so we're really in complete control of the aneurysm. And now we're trying to preserve the little vessels, separating them from the dome, which we accomplish, and then placing the tines of the clip between the little vessels right here. So we preserve the vessel, adding on one more little clip to get complete obliteration of the aneurysm and still have good flow with the remainder of the vessel. Another patient, subarachnoid hemorrhage from this ICA aneurysm, really no good endovascular option. And again, here you're talking about an ICA aneurysm, post fossa, down deep, no retractors in place. 7th and 8th nerve sitting off to the side. Basilar artery, we have proximal control of the basilar artery, but certainly no distal control. And now the whole goal is to create an opening for the tine of the clip to pass underneath so that we can occlude it and yet preserve flow. And so with sharp dissection and with blunt dissection, work on establishing this adhesion to the pia arachnoid from the aneurysm. But again, you see, there's really no retractor in place. Surgeon is in a comfortable position. This is not sitting position. And now we have enough room to place the tine. We occlude the aneurysm and then do an ICG to demonstrate that all the little vessels are open. What about more complex ones? Middle cerebral artery, memory loss, large dominant hemisphere aneurysm. There are branches coming out of the aneurysm, unusual, but it certainly does happen. And so now when we're looking at the Sylvian fissure, we put clips on the vessels that are coming out of the aneurysm, cut them off the aneurysm, then get down to the base and take out the aneurysm altogether so that we have room for the bypass. So we have 3 vessels that require blood. And so I have 2 of them very close to the M2 segment. So I take both of them and with sort of a figure 8 stitch, we attach both of them to the M2 segment. And then we have 1/3 one left that's distal, and we use the STA in order, and here you can see both vessels filling. And then you use the STA for an end-to-end bypass to the 3rd branch. And so this is basically what we did. On the angiogram, you can see the vessel coming up and filling both branches. and then the third branch being filled by the STA, SCA. Here's one that required help from my endovascular colleague, Dr. Albuquerque. Large, again, dominant, presenting with aphasia and hemiparesis. This is mostly thrombosed again, but you have this channel going through the aneurysm, feeding the left hemisphere. And what did we do? We did a double barrel bypass, straightforward. We only compromised the middle cerebral artery, didn't occlude it completely. 5 days later, we tested to see whether the patient could tolerate occlusion of the middle cerebral artery. Dr. Albuquerque performed that. When the patient was able to tolerate it, he then put in a number of coils to shut this off altogether. So after the coiling, this is what you saw. This is what you saw. Post-op, here are the coils. Post-op, you still see a little bit of filling of the aneurysm right here, right after surgery. And 1 month after surgery with repeat angiogram, that portion was gone as well. He ended up doing very well. Largest aneurysm I ever saw, 14-year-old. Obviously, no way to clip it directly, no way to coil it. So what we did is, here you can see that aneurysm coming up, pushing all the way over to the right side, and then the channel going through and then filling the left hemisphere. So we did a double barrel bypass. This was a long time ago, and then occluded the middle cerebral artery just past the lenticular striate. So here you see the internal carotid artery injection. You still see lenticular striates infecting, and then the STA filling his left hemisphere. And then we were fortunate enough to get a 13-year follow-up. This is what we started with. This is what ended up in 2004. And you see the bypass originally in 91, and then the bypass maturing as seen in 2004. And how do you get out of trouble? This is a patient, 71, recurrent aneurysm over and over again. We decided to treat it directly. Here's pica that you see sitting right here. Temporary clip on the vertebral artery proximal and distal to the pica, takeoff, opening the aneurysm. And then when I tried to clip it, when this is the actual clip going on the neck, I had the feeling that there was a little jump. And sure enough, when you take off the temporary, it's bleeding. What I did was tear off the neck of the aneurysm from pica. So now we have a hole in the vertebral artery, and we have pica now completely disattached from the aneurysm. So we're closing the hole in the vertebral artery with the pica, putting it back to where it belonged. And that really, here I'm taking off the proximal clip. Here's the anastomosis right here. And sure enough, pica's filling very nicely with ICG. And when, here's the post-op picture. And here you can see pica looking normal and the aneurysm gone. So how do we plan when we have complex aneurysm? There's one that was treated elsewhere in 91 with 2 clips, in 2000 with 1 clip, in 2001 with 3 clips. Aneurysm recur all the time. Pictures with permission of the family. So the first thing we do, we study the angiographic picture. And what we see is the following. We see that this, first of all, it's a dissecting aneurysm. No matter how many clips we put on, that's going to recur. It is not, it is an M2 branch, so it doesn't fill everything. There are branches that are before the takeoff of the branch to the aneurysm. And then we notice that the anterior temporal artery is intact. So if we can occlude the middle cerebral artery branch, 2 branch here, the aneurysm will be gone. We just have to revascularize that particular portion. So we're going through all the scar tissue. We see the middle cerebral artery down here. So we have good proximal control. We go around all the scarring to find the distal vessel, and so that we can anastomose to it. And then we look at the anterior temporal artery, and it's actually going into the dura from the previous surgery, but it has good flow in it. So we use it to do a bypass distally with a Levenot suture, and then occlude, just like we showed on the pre-op angiogram, the M2 branch that leads to the aneurysm. And when we do ICG, we see the filling of the bypass very nicely, the branches that we wanted to preserve. And so this is what we see: anterior temporal artery going around and feeding that portion of the left hemisphere. And finally, as the last case, this is really what it's all about. Our patients, a little 18-month-old with a subarachnoid hemorrhage with this dissecting aneurysm. And when we have it exposed and I cut off the section, we have this big hole in the aneurysm. So I'm taking the frontopolar branch from the other side and using it not only as a fixing the hole in the end, but also as an additional bypass. So here we see proximally, we see the bypass coming in as well. Oops, sorry. And so that's what it looks like. So this is basically what we did. And then this is what we get rewarded with. 5 years later, Amanda's the smartest girl in the class, and that's what it's really all about. This is a complex slide I put together. Basically, what we're looking at is when you look at a remnant, it's very small. The risk of hemorrhage is very, very small. As it gets larger and increases in size, that goes up. When we look at clip obliteration, though that is the percentage of clips of aneurysm obliteration as adjudicated by an independent neuroradiologist, we're at 87, 88, 95, 93. It stays up. It's very high complete occlusion rate. When we look at the endovascular treatment, we have clip obliteration at 52% to start off, and then going all the way down to 22%. So when you look at this over time, what really happens is this is when the risk gets up there. That's when the aneurysm is large enough to represent a risk of subarachnoid hemorrhage. And that's why we had those 2 subarachnoid hemorrhages there. So is aneurysm clipping dead? No. There are many cases that require microsurgery, clipping, bypass, etc. We must remember that in Brad, 36% of patients were crossed over from coil to clip. There is no significant morbidity and mortality at the time. Now, you've got to remember that longitudinal studies of aneurysm, they are so influenced by cardiac disease, by trauma, etc., that little percentage risk is not going to show up. Our only goal is to prevent subarachnoid hemorrhage. That's what we need to be looking at. Risk of rebleeding, retreatment, and obliteration, favoring clipping, nuances, correct positioning. This all sort of been. Collaborative efforts remain mandatory. Our endovascular colleagues clearly are here to stay, and we have to work together. So in conclusion, Fred, that smiling face will be missed. Gina, my condolences to you. You are a very special person, and it's been a privilege and honor to be your friend. Thank you.
Thank you for that, Dr. Great case illustrations there. And we have a question in the chat from Dr. Somali regarding timing of treatment. So is there a best time for clipping or coiling regarding maximum vasospasm period, or should we treat the aneurysm as soon as possible regardless of the technique used?
My philosophy has been to treat as soon as at all possible. The reason being is that the highest risk of rehemorrhage is in the first 24 hours. And it only goes down slowly after that. So if you treat a couple of weeks afterwards, you may very well have better results in the sense of less perioperative complications. But overall, you will have a greater morbidity and mortality if you include the patients that died during that waiting period.
Thank you. I have a question just on, so you've demonstrated some very complex cases there. And in terms of the future of aneurysm surgeons, how do you foresee sort of training the next generation of aneurysm surgeons in terms of building up appropriate experience to manage to treat these cases appropriately?
Daniel, I think that's a very good question. But I think what has happened over time is that aneurysms were treated by every neurosurgeon in local hospitals at all times. And what has happened with the legal situations, as well as seeing the results of that there has been a greater and greater tendency to refer aneurysm patients to bigger centers. And in the bigger centers, it is mandatory that we subspecialize so that when somebody sees an aneurysm, it doesn't go to the spine surgeon, but it goes to the vascular surgeon. And there you have to have a team that includes endo and open. I do not think that having hospitals that only have endovascular service is appropriate for patient care.
Thank you. A couple more questions about learning curve, and I think that's sort of learning curve, microsurgery, suspensional radiology. And I guess I'll take your view, but I guess that's different areas of microsurgery complementary as well. It's not just that you're an aneurysm surgeon, but you have the microsurgical skills from other areas of your neurosurgical practice that complement it. What's your thoughts on learning curves for microsurgery?
I think we can safely state that endovascular treatment is technically easier than microsurgery. And so we have to be very careful that we don't use an easier technique just because it's easier. We should only use it if it's really the more effective and the more appropriate one. And I think that's a difference that when it comes down to the individual surgeon, they have to be able to look in the mirror and say, this is how I would treat my loved one or my Gina. So it's ethical, appropriate point. Practice. The beauty today is that there are so many ways to get better microsurgically in the laboratory. I mean, whether you don't have to have a cadaver, you can use chicken wings. I mean, there's so many ways to really get better that it's your obligation, if you're going to treat your human being patients, that you are the best you can be.
Yeah, definitely agree. And there's one final question just on angionegative subarachnoid hemorrhage. And I guess it will partially depend on perimesencephalic or perimesencephalic plus or diffuse. But what's your approach to imaging and repeat imaging in those initially angionegative cases?
I think when we have a perimesencephalic bleed and it's mild and your first test is negative, I always like to get a second. I mean, we have the non-invasive ways of looking at the blood vessels today really allow you to find a point of suspicion. If there's a point of suspicion, just like with that basilar artery aneurysm I presented, that subarachnoid hemorrhage was more than our usual mesencephalic bleed that is benign. The course is benign. And so if you're suspicious, I like follow. In this case, I did a repeat angiogram while the patient was still in the hospital because the patient was pretty sick from the subarachnoid hemorrhage. And once you identify that bleed, obviously, then you treat it.
And that's your clue, I guess, is the patient is sick, then look again.
Right.
Well, that's great. That was a fantastic talk. Thank you very much. And thank you for joining us live. I appreciate you not feeling at your best. Much appreciated.
Dan, is it okay if I just interject?
Yeah.
Just let you know, Dr. Spetzler, 2 days ago already had sent video recording. So, but he still wanted to give this lecture, even though he's have the COVID. So can I go to everyone's microphone? Can I please give a clap?
Thank you for making me feel better already.
Thanks. Thank you.
Very good.
Thank you.
So
Thanks.